All right, so it is a great pleasure to introduce Keren Bachi. Keren is an assistant professor of psychiatry, environmental medicine, and public health, and assistant director of the clinical research of the, assistant director of clinical research of the Addiction Institute at Mount Sinai, or AIMS as we know it. Her multidisciplinary research focuses on the neuropsychosocial pathways involved in disorder progression and recovery in substance use disorders. She uses a systems approach integrating brain, periphery, and environmental factors to explore neurobiological underpinnings of psychosocial determinants of health and to facilitate the development of novel prevention strategies, diagnostic tools, and interventions. As the Assistant Director of Clinical Research in AIMS, Dr. Bachi also conducts clinical trials of novel pharmacological interventions for the treatment of substance use disorders. So Keren, thank you for joining, and look forward to your talk, and I'll turn it over to you now.
Thank you for having me and for this opportunity to share our exciting work. Yeah, and please feel free to ask questions during the talk if anything is urgent. So today I'll talk with you about setting the stage for personalizing treatment of substance use disorders, neuropsychosocial determinants in this context. I want to start with considering two patients, J and P, who are patients with diagnosis of severe opioid use disorder with no psychiatric or physical comorbidity. Both are admitted to addiction treatment consisting of detox followed by an outpatient rehab program. Now, the current treatment approach would likely be similar for these individuals, despite significant differences in psychosocial presentation that impacts their adherence, compliance, and prognosis. So Jay is a 30-year-old, first admission, grew up in a functional family, has a profession, a significant other, and stable housing. P, on the other hand, is 58 years old, with multiple prior admissions, has history of childhood trauma, no profession, is unemployed and homeless. The current treatment models are likely to be effective for J and to be insufficient for addressing the needs of P. And despite enormous medical and societal burden of these disorders, little has changed for decades in developing treatments and care regimens that consider multidimensional psychosocial and clinical factors that will facilitate personalized care for subgroupings of patients. The current one-size-fits-all model needs to be replaced. The Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, is an important structural tool used to clinically diagnose mild, moderate, and severe substance use disorders, but the classification are based on numbers of criteria that may or may not address severity or have any relevance to treatment. Moreover, this classification system does not fully account for the multidimensional factors, particularly in complex pathological manifestation, like we saw in the cases of J and P, that they would get a similar DSM severe diagnosis despite a very, very different presentation and treatment needs. Now, let's consider again these examples. So in opioid use disorder, similar across these patients, can we consider that their disorder is similar? Can we consider that their clinical presentation, does it represent a biologically distinct subtype? Can we consider their phenotype and treatment trajectory comparable? Our question is whether it is feasible to stage patients to, despite similar DSM-5 diagnosis, to personalize the treatment for patients with substance use disorder. And my research program centers on examining the neural underpinnings of psychosocial factors in substance use disorders to provide a foundation for this novel treatment approach. Now, we know that there are multiple factors that impact disease trajectory. Here's a proposed model of an interaction between genetic disposition and early environment leading to vulnerable phenotype, where subsequent exposure to stress or trauma throughout the life, which is very prevalent in our population, unfortunately. This subsequent exposure may induce exacerbation of pathology based on underlying vulnerability. And we must also consider resilience-inducing factors. So social support or coping style may buffer the effects of early life stress on vulnerability, which will determine the ultimate long-term mal or adaptation to functioning in life. Now, I focus on childhood maltreatment as it is one of the major psychosocial factors that impacts addiction. Adverse childhood experiences account for 50 to 75% of serious problems with drug use and increased severity of substance use disorders. Now we know that the clinical long-term impact of treatment, maltreatment in addiction is quite known. Maltreatment individuals have a earlier age of onset, greater symptomatology, as you could see in this list. Now, brain alterations following drug use are quite established, but how about pre-morbid variants in brain structure, function, and neural circuits of individuals with substance use disorders? Whether and how do brains of individuals like patients J and B and P differ? We will look today at morphological, functional, and circuit level at rest impacts of childhood maltreatment in individuals with substance use disorders. But before we go into the data, I want us to have a closer look at childhood maltreatment, which has been associated with alterations in key structures that make up the reward system and mesocortical limbic pathway, which is here in red, and nigrostriatal pathway in black, which ascend the dopaminergic pathway, which is represented here in green. All of these pathways are core pathways in addiction. This depiction is in context of trauma, but these are also core pathways in addiction. And childhood maltreatment is also associated with changes in structural connectivity at the network level, where here you could see data of young adults who have not been maltreated as children. It's a summary of 123 young adults who differed from those who have been maltreated and exposed to trauma, the lower panel, which includes data of 142 young adults, in regions that work together to mediate perception and regulation of emotion and the urges. So the left anterior cingulate was highly centralized region and neural hub in controls, but not in those with history of maltreatment, which may lead to reduced ability to control impulses or make appropriate decisions based on past outcome. The right anterior insula was centralized region and neural hub in maltreated participants, but not in the controls, which may lead to more intense craving for drug coupled with diminished insight into consequences of such use. And lastly, here we could see that the right precuneus, a region associated with self-centered thinking, had high centrality and was a neural hub in the maltreated study participants, but not in the controls. These findings indicate that the altered cortical connectivity in maltreated individuals may put them at a much higher risk for addiction if they start down the road of drug use. And the alterations in mesocortical limbic pathways following trauma is evident also with reductions of gray matter, including frontolimbic and frontostriatal regions, where independently drug addiction is associated with reductions in gray matter volumes across several of the same regions affected by childhood maltreatment. So again, the overlap is evident, but what is the unique contribution of childhood maltreatment as pre-morbid factor predating drug use to structural alteration in addiction? And we ask if there are clinically relevant imaging biomarkers that could help us identify and predict a possible future addiction. And also, what are the clinical implications of such biomarkers? So our recent review that was conducted by our senior clinical research coordinator, Vioma Sahani, summarized the current existing 21 studies in individuals with substance use disorders. So, from a quick look at literature, despite the importance of this phenomenology, the body of literature to date is very, very small. It's only 21 published studies. And so we looked at the literature that looked at individuals with substance use disorders, showing the effects of trauma during childhood on gray matter volume and concentration, as you could see here, and the effects of this exposure to trauma, also the effects in adulthood on brain connectivity in this population, where we see a distinct overlap between social stress-related circuitry and addiction circuitry, particularly in brain regions implicated in drug-seeking, craving, relapse. And evidence that accumulated to date needs to be, of course, replicated and extended, particularly using research designs and methods that disentangle effects of substance use from the trauma. As I noted earlier, brain alterations following drug use are quite established, but how about these premorbid variants in structure of individuals with substance use disorders and its relation to clinical presentation? So whether and how do the brain structures of individuals like patients J and P differ? We examined the potential long-term effect of childhood trauma and integrity of gray matter concentration in 24 adults with cocaine use disorder with high childhood trauma, which are in red, compared to 23 with low childhood trauma with substance use disorder and 29 healthy controls, where a similar study, including healthy controls with high trauma, is currently ongoing. We found that childhood trauma possibly affects gray matter concentration at a premorbid stage, where individuals with cocaine use disorder with high childhood trauma in red had least gray matter in the right lateral orbital frontal cortex as compared to those with low trauma, which are in green, and healthy controls in blue. We also observed that reduced constraint and increased depression correlated with reduced structural integrity of the orbital frontal cortex, which suggests that individuals with cocaine use disorder who experience childhood trauma have greater psychological comorbidity as compared to other individuals with cocaine use disorder. So we see a distinct distinction between the two subgroups of individuals with cocaine use disorder with various clinical symptomatology, as we also see in the clinic. Furthermore, a post hoc analysis using hierarchical regression demonstrated that the continuous measure of childhood trauma accounted for 37.7% of the variance in gray matter concentration in the right lateral orbital frontal cortex, which you could see here in the third block, while constraint and depression explained only 10.2% of the variance in the second block. You could see that, which was above and beyond effects of age, education, total intracranial volume, and lifetime drug use variables. So beyond demographics and drug use and beyond constraint and depression, the experience of childhood trauma related to orbital frontal cortex gray matter concentration reductions. One of the main challenges of investigating social stress in substance use disorder is disentangling the effects of social stress from the effects of the substance use. And most current studies, as we summarized previously, use a cross-sectional design comparing individuals with substance use history and a trauma history to healthy controls. Only a few include a sample with substance use history and no trauma history, or healthy individuals with trauma history. Moreover, none of the studies that we reviewed or that exist to date did all of the above. So the absence of a healthy control group with trauma and a substance use disorder group without trauma means that it is impossible to confirm the unique neural effects of trauma in individuals with substance use disorder. We are currently analyzing data to replicate this previous study with a similar and separate cohort that includes individuals with and without cocaine use disorder and childhood trauma. So we observed that childhood trauma has long-lasting impact on structural integrity that is evident even though the drug use has been more recent, and in many cases for a longer duration in these individuals' lives. We next examined the impact of childhood trauma on brain function in substance use disorder. So long-term outcomes of drug use are associated with profound social dysfunction. We therefore examine, and a lot of our program or questions that we ask center on examining neural correlates of brain function during social function. And in this case, we're looking at social choice. We used fMRI task developed by Dr. Daniela Scheller. It's a social navigation task, which is a well-validated naturalistic fMRI paradigm that aims to capture how one navigates social decisions, considering questions of power and affiliation. Now, this task tracks an evolving social dynamic where participants are presented with a virtual role-playing game with a narrative of relocation to a new neighborhood, and they are seeking employment and housing, while they interact with 6 different figures. Here you see a schematic depiction of a trial type and task structure, where this task has 63 decision trials on encounters which participants are required to respond to, and half of the trials, half of the encounters relate to power, and the other half to affiliation. Here in this example, it shows a power interaction. And this task results in a 2-dimensional geometric representation of social coordinates, or a social space, if you will, which is framed by power, which is defined like being submissive or authoritative, and represented in the y-axis, and affiliation, which is framed by sharing private information or intimacy versus keeping social distance, which is represented here in the x-axis. And the example here shows a character moving through the course of 4 social interactions, where the blue line has a trajectory to point of interactions from the point of character's origin. And to calculate the social coordinates, we drew a vector between the theoretical point of view of maximum intimacy and neutral power and the character position. So for each social interaction, we calculated the vector angle, which represents the dynamic computation or decision of power modulated by affiliation in one score. And in an independent sample of healthy individuals, hippocampal bold activity predicted changes in subjective affiliation and power between people and the fictional characters. And this hippocampal activation was positively associated with actual social navigation and social skills. We recently replicated these findings in hippocampal activation outcomes in an independent sample of healthy controls. If time allows, I'll be happy to show you these outcomes as well later on. So we have now very recent and exciting results of neural underpinnings of social interaction vis-a-vis real-life social competence using this task, examined for the first time in addiction or any patient population. Our sample included 30 individuals with cocaine use disorder and 33 healthy controls. That's after excluding participants for memory and high motion, or quality, I would say. High and low childhood trauma was similarly distributed in both groups. The analysis included the egocentric angle parametric modulation model, and the second level analysis included the analysis of covariant, including variables of group, childhood trauma, questionnaire score, age, and sex. And we did a post hoc analysis that looked at classification of cocaine use disorder status. We used region of interest. We use a hippocampus region, which is implicated in childhood trauma and also was implicated in social decision making in this task. We also used regions of prefrontal cortex, specifically in the right inferior frontal gyrus, which is has been implicated in addiction, trauma, and also had the largest estimated relationship to spatial decision making. We also had a control region of the motor cortex to examine whether there is any specificity in these regions that we looked at. So here's an overview of our sample, which includes these 33 controls and 30 individuals with cocaine use disorder. Demographics are not differing between the groups. There are more years of formal education in the control group. However, the verbal and nonverbal cognitive performance is equivalent. Therefore, it was not included in the model. The childhood trauma is equally distributed across the groups. In the cocaine group, we see over 20 years of heavy drug use. So our results, analysis of covariant, points to a childhood trauma effect in which the greater the childhood trauma, the less hippocampus activation during social choice. These results are consistent with previous trauma research where the hippocampus region is important in memory processing and emotion and stress regulation. I would also say, I mean, these results are, you know, in this sample of controls as compared and replicated previous studies, the controls had a greater hippocampus activation also in the replication study that we conducted previously. So these are quite, I would say, exciting findings. And we also observed drug effects while controlling for childhood trauma, where healthy control has a greater activation in the inferior frontal gyrus during social choice, where the right inferior frontal gyrus has been implicated in inhibition, risk attitudes, and attentional control. And all of these results had a small volume correction for multiple comparisons, of course. Our next analysis used the outcomes of childhood trauma effects on brain function. Here, the activation during social choice to classify the cocaine use disorder status, and using the average accuracy from leave one out classification method with 1,000 permutations, the activation in the left hippocampus followed by the activation in the right inferior frontal gyrus accurately classified the cocaine versus control groups. And interestingly, the results were specific to these regions where such classification was not accurate using the control regions such as the motor cortex. So we observed the long-lasting impact of childhood trauma on brain morphology and brain function in cocaine use disorder. We next look at the network circuitry at rest, which is independent of task demand. So here are the main network circuits that are implicated in substance use disorder, where on the left side, there is a schematic anatomical representation of the mesocortical limbic dopamine system in the human brain. We're highlighting several key processing regions, where on the right side, the B, 4 of the frontostriatal cortical circuits that appear to play major roles in executive functions and inhibitory control. So the observable behaviors that characterize the addiction phenotype, which is compulsive drug consumption, impaired self-control, and behavioral inflexibility, represent an unbalanced interaction between complex networks that form functional circuits, I would say, which are implicated in goal-directed behavior. Our next question is, how do these circuits in substance use disorders how do early maltreatment impact the network connectome in substance use disorders? Now, because of the long-term outcomes of drug use, which have profound social dysfunction, we examined connectome differences related to network architecture on the social brain. So of the original sample of 77 individuals, 8 were excluded for MRI quality, reaching a sample of 69 individuals. This work has been led by our former postdoc, Dr. Tien Tong. So using a median split of childhood trauma questionnaire, we divided the sample into 20 controls with low trauma, 20 controls with high trauma, 12 cocaine use disorder with low trauma, and 17 cocaine use disorder with high trauma. And you can see the trauma distribution in the sample, where, I guess it's a little small, but the low trauma had a mean of 29.6, and the high trauma had a mean of 60.7. Where just for comparison, in the general population, the mean of trauma of low trauma is 34. So this is a representative distribution, I would say. The analysis included a pre-processing with multi-echo independent components analysis with smoothing and band passing the data. We had a region of interest of 44 social brain regions with a 6 millimeter radius sphere. And we used the approach of network-based statistics, which is a well-known tool to perform statistical inference on brain graphs, which controls the family-wise error rate in a mass univariate analysis by combining the cluster-based permutation technique and the graph theoretical concept of connected components. We also are now conducting post hoc on network level connectivity analysis. It's ongoing. All of the results that I'm showing you are very fresh, I would say, even from the last week. So it's work in progress. Typically, network-based statistic has always been applied to t-test only. So here we're taking it to the next level. Before showing you the connectome results, here is an example of how social dysfunction impacts real life in our sample. So we conducted an analysis of variance using a total score of experience in close relationship scale, which is a sum of anxiety. Like, for example, one item is, I need a lot of reassurance that I am loved by a partner. And avoidance, which is, for example, I try to avoid getting too close to my partner. So all of these questions are in a context of a close or romantic relationship, if you will. And we observed that the most significant trauma effects and drug effects between the groups. And we also observed a trend for an interaction effect where cocaine users with high childhood trauma had the greatest anxiety and avoidance in close relationships as compared to those with low trauma and healthy controls with and without trauma. We next plan to test how these and other social functioning results associate with resting state outcomes. So let's go back to the resting state outcomes. And in our network-based statistics, we first define the regions of interest using 44 social brain regions based on this publication of Lopez from 2018. They have a very nice comprehensive publication on that it's based on meta-analysis of the social brain, if you will. And we observed that we observed a drug main effect where the important nodes in which healthy controls had a greater connectivity in the limbic regions, which included the nucleus accumbens, ventral medial prefrontal cortex, and higher level regions, which included the dorsal medial prefrontal cortex as compared with individuals with cocaine use disorder. We also found a trauma main effect, which the important nodes in the limbic regions, ventral medial prefrontal cortex, and amygdala, and higher level regions, including the precuneus. And this effect was significant. And we next found an interaction effect, an interaction of drug by trauma effect, where was the most significant, where important nodes included the intermediate network, including the insula and the inferior frontal gyrus and visosensory regions. So notably, if we look at this data, we see that the interaction effect is the most pronounced effect. And again, we see the pattern of the trauma has much stronger effects than even the drug effects, which again, despite the recency of drug use, I mean, these are individuals that they are in their mid-40s. Trauma refers to trauma that has happened before they were 18. So it's many years since the trauma has happened and many years of cocaine use since then. And despite this difference, we see long-lasting effects of trauma on these network architecture. We are now conducting post hoc analysis to further understand and interpret these findings in the 4 group. It's an ongoing effort. We are basically did pairwise post hoc tests, which we run on the network level, looking at average edges of each of the same networks, where we found 74 edges from the cluster that show a significant interaction effect, where notably 3 out of 4 significant network interactions, which are highlighted here in red boxes, they involve the visual sensory network. This network is important for bottom-up processing of biological and socially relevant stimuli, fusiform for face processing, visual and motor for processing that is often implicated in the mirror neural system and reflective functioning, which is core to social functioning. So in summary, we observed long-lasting morphological and functional marks of trauma on brains of addicted individuals. We found reduced structural integrity of the orbital frontal cortex, which associated with greater psychological comorbidity in individuals with high trauma. We also see that greater trauma associated with diminished activation in limbic regions and hippocampus and in the inferior frontal gyrus during social choice. We also saw that controlling for childhood trauma effect, activation in the left hippocampus followed by the right inferior frontal gyrus accurately classified cocaine use disorder status. And finally, the interaction of drug by trauma effects in the intermediate level subnetwork known for cohesive response, such as empathy and pain tasks, and in the visual, sensory, and limbic subnetworks, which are known collectively to be responsive to facial and other biologically relevant cues with immediate relation to perception, action cycles in social cognition. So altogether, childhood trauma has profound neural marks despite the recency of substance use disorder. So after observing and seeing all of these profound morphological and functional and neural effects, we ask, how can we utilize this knowledge to improve treatment? And despite advances in characterization of substance use disorders as a chronic brain disease, specific clinical stages have yet to be established that are linked to individualized treatment as other chronic illnesses. And it is time for the field to incorporate a staging model that we would like to propose, like in other clinical disciplines, into the diagnosis and treatment of substance use disorders, which is critical for improved patient outcomes and expanding the impact of clinical research. What we propose is a dynamic structured staging model for substance use disorders that incorporates multidimensional factors, including social determinants of health, that could improve personalized treatment and enhance clinical translation of addiction research. So, the classification of a disease is a fundamental aspect of scientific medicine, and staging models are used routinely in general medicine for potentially serious or chronic physical disorders such as diabetes, arthritis, cancer, where they describe links between biomarkers, clinical phenotypes, and disease extension, and they promote personalized or stratified medicine approach to treatment planning. This is just a general definition of staging. And we looked at lessons that we learned from staging in other disease models. For example, in cancer, staging is used for treatment guidance and prediction of survival rate. In other diseases that are biologically well characterized, biomarkers provide reference for staging. There are several biomarkers that are known in substance use disorders, such as liver enzymes that are associated with alcoholism, but by large, much more work is needed to establish predictive biomarkers. These are part of our efforts on the neural levels, but of course also peripheral biomarkers are super important. Now, looking into other disease models, so looking at neurodegenerative diseases, we see that functional impairments is accounted in staging. Notably, in many of these staged conditions, there is a linear disease progression. Now, in psychiatry, the nonlinear nature of disorders add on another layer of complexity to form staging, where clinical staging in psychiatry builds on a strong epidemiological evidence that indicates what we regard as a major mental illness that evolves over time in terms of clarity and severity. Here in the context of depression, another example that shows the complexity in psychiatry is in schizophrenia, which is triggered by complex pattern of genetic, epigenetic, and developmental and environmental factors, which of course are recognized in the first well-defined psychotic episode. But these examples point to the challenges of utilizing staging models within psychiatry. And there are several attempts of developing staging in psychiatry where they generally central or focus on general symptomatology, as shown in this example, a lot of clinical decision-making and not so structured, I would say. Here is another example that also accounts for overlapping comorbidity as well as possible neural and peripheral biomarkers. And again, of course, the overlapping comorbidities, again, yet another layer of complexity of staging in psychiatry. Now, in substance use disorders, there were great pharmacological advances of treatment per various parts of the addiction cycle. But however, pharmacotherapy in addiction, there is still a unidimensional approach that needs to take into account the psychosocial complexity and variance across stage and severity of presentation. Again, going back to our case examples, J and P, how can we create better responses to their conditions? This is what drives us. So, going back to what is known in context of substance use disorder treatments, one of the leading the leading founders of methadone treatment, Dr. Dole, one of his quotes really, I think, represents the complexity in our context. So he says secondary goals present more of a problem in definition and evaluation. Alcoholism, non-opiate drug use, psychopathic behavior, and delinquency are not stopped by methadone or any other medicine, nor can any medicine provide a patient with a job, stable home, self-respect, or happiness. Even with the best supportive services, achievements in these areas may be limited by factors beyond the program's control. And one of the questions that we ask is, where is the limit of our treatment, the program's controls, and so on. And in developing a staging model that we're conducting now, we're conducting focus groups with clinicians of various disciplines in the Addiction Institute. We are now also interviewing patients who successfully moved from advanced or late stage to early stage to learn about the important factors that impacted them, their treatment, and barriers in their recovery process. And these are just examples of some of the factors that we are considering and taking into account in the model, where the staging and the classification needs also to account for primary, secondary, and tertiary levels of disorder and care. And what we are proposing in our staging model, which ultimately will need to be tested, evidence-based, and also with contribution of leading experts in the field, together with Dr. Ed Salsitz and Dr. Yasmin Herd, we are developing this staging model, which accounts for psychiatric comorbidity, medical comorbidity, social determinants of health factors, trauma history, number of past treatments, treatment non-adherence, lack of self-efficacy, and also the DSM diagnosis. But that, in addition to all of these other factors, so this model, which patients could be diagnosed into early, moderate, or advanced or late stage, accounts also, our thoughts are that evaluation would need to be repetitive, depending on presentation, because of the dynamics. So people could theoretically move between stages of their disorder, and accordingly treatment would be derived from these stage of presentation that they have, where in different stages. So for example, in stage 2, people would have more psychosocial syndemic focused treatment. In later stages, consideration of palliative care could be most important for some presentations, and so forth. And this is a work in progress. It's in development. Our intention is later on to conduct a pilot within the Addiction Institute. And the beauty of it is, we can really move between research and clinic in our Addiction Institute to test and utilize and sharpen what's going on in the clinic. And we need to also consider some challenges, limitations, part of the discussions that we are centering in this process, where during defining standardized stages in addiction. So, questions of what is recovery, what is the ultimate goal of treatment per stage, ultimate aims for subpopulations like palliative rehab, and the need for research evidence to ground staging and personalized treatment. And finally, to develop and test novel patient-centered treatments. We have been discussing development of trauma-focused care that is specifically for context of substance use disorders. And all of this work is done with a lot of efforts and contribution of many people, including Dr. Yasmin Herd, Ed Salsitz, Tien Tong, Vioma Sahani, Chris Kordach, Anna Pandolfi, Philip Camillar-Britt, who was our former coordinator, and our collaborators, Dr. Schaefer, Schiller, not doctor, still student, sorry, Dr. Schiller and Dr. Yael Jacob. Thank you so much.
Thank you, Keren. I noticed in the chat, Ria reminded people that there is a link for CME credit for psychologists. And now it's time for Q&A, and since this is webinar style, you have to put your questions in the Q&A panel. So, and we can unmute people if needs be, but people can start by just comments, feedback, and questions into the Q&A box. I'll just say, Keren, there's a lot of interest. You have a lot of participants, and I know there's lots of questions. So here is Nellie's asking, are there any good questionnaires for neglect?
We have several questionnaires that we use. We recently started using the MACE, which has been developed. It's a maltreatment. Oh, I'm not good with the acronyms. Developed by Marty Teicher, who is a big expert in trauma field, who has developed this questionnaire that looks into, it's a 52-item questionnaire that looks into not only abuse and neglect, it accounts for 10 forms of trauma and abuse and neglect, but also the chronicity. So that really gives much richer data that we're accounting for currently, yes.
All right. More questions? Gosh, it's a large but quiet group this time. Oh, maybe people are just typing. So Keren, you can open the Q&A, but I can also. So Mohammed says, "Great talk, Keren, and would like to hear a bit more about the interaction you saw in your fMRI data between trauma and cocaine use. From your plots, it seems that a lot of the variance is driven by high versus low trauma in controls, and not so much in cocaine users. Now, what does this mean in terms of the connectivity patterns?"
Yeah. So let me go back to this. Sorry. Where is that? We're looking at these. So, this is part of the questions that we're trying now to respond to with post hoc analysis that we're conducting. It's really very, very, I would say, recent outcomes that we found. So we're still trying to wrap our head and interpret and understand. Also, yes, so it sounds like it's really very pronounced with the trauma effects. And this is part of, I would say, it's a pattern that we see across the different outcomes, morphology, and also, I would say, circuit level. I think for me, one of the important things is, okay, how does this associate to real life social function? So taking it to that context in terms for us to drive afterwards clinical implications. But I could share that in the next talk because it's work in progress yet.
Thank you. And then a couple more questions coming in. A question about how much do you trust or rely on childhood trauma reports, given that the participants are in their 40s?
That's a good question. So, there has been quite a bit of work that looked into validity of self-report with different questionnaires of childhood trauma, and across many meta-analysis and studies, it has been shown to be quite valid. I must say that also in our sample, when we invite people for different protocols, they're reporting, even if 3 years lapse between participation in different protocols, the reporting is quite consistent. And we account for the trauma with reporting with different instruments that, again, have been quite established and validated. Of course, ultimately, if we could do longitudinal studies, that would be superior, but that would be very challenging to conduct.
All right. Are there correlates of people who had childhood trauma but did not develop a substance use disorder? I'm not sure I understand that question, but maybe you do, and if not, we can clarify with Eduardo.
So this is exactly what we're aiming at to disentangle with the four-group design, right? So we're looking at individuals that are healthy controls with high trauma without substance use disorders, and individuals with healthy controls with low trauma, and substance use disorder with high trauma and low trauma. So this is exactly what we're aiming at disentangling. And for those with a childhood trauma that did not develop substance use disorders, that's a great opportunity to learn about resilience and supportive factors that perhaps buffered the development of substance use disorders. So this has a lot of clinical implications as well.
All right, and one more question from Dana Schiller. Could you speculate about the role of hippocampus in childhood trauma versus addiction?
Yes. So actually, that's a great question. And in the post hoc analysis that we are still conducting with the social navigation task, we're a little underpowered, but we're collecting data, so we're hoping to be well powered to really, again, in the social navigation outcomes, we looked at cocaine use disorder versus controls, but not the four-group design. So I think that once we will be powered enough to do the four-group analysis in this, then we'll be able to really better understand the role of the hippocampus in trauma versus addiction in our sample. Generally, it's I would say it's a complex on other levels, in the sense of the implication of hippocampus in navigation and in memory. I mean, there is here I would say functions that are relevant to both childhood trauma and addiction. So I would think that we would need also to follow up with additional studies that look at these specific aspects in terms of the memory formation and so on between childhood trauma and addiction to further understand that. So.
All right. Well, thank you, Keren. Mohammed has another question. Okay, childhood trauma questionnaires ask for several different types of trauma. Are the effects you see trauma type general, or would you expect trauma types to interact more stringently? I guess some trauma types interact more stringently with substance use. Strongly.
So I agree. I mean, look, we have a lot of work to do in the sense of, at the moment, we're accounting for general trauma effects. Later on, as we will be powered enough to start looking at types of trauma, chronicity, we'll be able to further decipher. For example, sexual abuse has a lot of targeted impact on the limbic system as compared to neglect, emotional or physical neglect or abuse, and that may have direct implications on the neural and other social functioning or so on. So I think it's the main challenge here is for us to further take it to the next level and perhaps using larger data sets that account for these aspects so that we can be powered enough to answer such questions. Absolutely. And then also derived specific treatments as consequence from such studies. We have a lot of work to do, I would say. but the take home, I think for all of us is if it's possible to include such factors in different types of studies across psychiatry, then we could be powered to look at these questions even transdiagnostically.
Yeah, absolutely agree. Well, thank you, Keren. Thank you all for all the participants.
Thank you. Thank you for this opportunity.
Yeah. See you all in a couple of weeks for the next talk.